Morena koutou, me karakia tia tātou. Whakatakata hau ki te uru, whakatakata hau ki te tonga, kia mā kine kine, ki uta, kia mā taratara ki tai. E hi ake ana te atakura, e teo, e huka, e hauhu, ti hei Māori ora. Morena, everybody. We've got a very busy agenda today, so I'm not going to hold things up. So I'd like to introduce Hayley McElwain, who's the Senior Service Development Manager, Aging Well Commissioning in Health New Zealand, Te Whatuora. So she's going to give us a brief introduction or presentation to explain the work developing the health workforce plan. So, Morena, Hayley.
Kia ora, Teresa, thank you. Hi, everyone. Kia ora koutou, ko Hayley McElwain toko ingoa. Thank you for having me today. As Teresa said, I am in the National Aging Well team. I joined a few months ago, and I'm here today to talk about the Te Whatuora's Health Workforce Plan. So I'm just going to share my screen. If you bear with me for just a second. And I'm hoping everyone can see that. Good to go. Okay, so I'm just going to talk hopefully for 10 minutes and just to give you a brief introduction on this piece of work and then why I'm here today, what I'm asking from all you wonderful people. So in 2023, Te Whatuora published its first national health workforce plan. And of course, this was the first time Te Whatuora had done such a plan because we had only existed for a year. The focus of the plan was Health New Zealand's response to the employed health workforce of New Zealand. And so that wasn't just the workforce employed by Te Whatuora, but the system as a whole. It was designed to relieve some of the current workforce pressures that that the system had been experiencing and to meet the challenges of the future. And it had a 365-day focus. It addressed it acknowledged our current situation and gaps, and then some goals and actions to address those gaps. And so, of course, we are going through that exercise again. The plan that's currently in play is for 23-24, and now we're rewriting the plan for 24-25. As part of this work, there was some reflections on the successes and then some areas of growth that we could make in the coming year. So it was good to have a plan and to be honest about the problems that we were experiencing in Aotearoa in terms of our health workforce shortages. But for those who have read the plan, you will note that there is primary and community, there's not a lot of information about that sector. And of course, the primary and community health care workforce represent the largest workforce in the country, and people get most of their care when they're in the community. It was very hospital centric, and again didn't explore opportunities for the primary and community sector, and that we didn't really get the balance right in terms of short-term actions versus long-term actions, because there was that real let's look at the next 12 months, that I think one of the figures in there is that we are short 4,000 RNs or more than that, but addressing that in 12 calendar months is nigh impossible. So to do some thinking that was more future focused. Upon reflecting on this slide specifically, I think there are some other areas that I should just highlight. The Kaiawhina workforce was nigh non-existent in the plan, or it was mentioned, but actions to address the shortages and the support needs of that workforce were very few and far between. The plan is, of course, focused on the workforce and did not look to conditions. So it didn't talk to any parts. It talked to an aging population and an aging workforce, but it didn't look to parts of the sector that require more focused work, like dementia, a workforce that is dementia capable. And then the third was that, as I mentioned when I introduced the plan, it talks to the employed workforce. So of course excludes those who are not formally employed. So those are caregivers, spouses, whānau who are caring for loved ones. And when the health workforce team approached our team to talk about getting members of the primary and community sectors engagement on the plan, they did highlight this as a gap, and had and although it would not likely be recognised in the 24-25 plan, did want to have the discussion about that workforce and its importance, and how we can support that group of people. So the approach to planning for this coming financial year will continue to have a national focus. There'll continue to be a focus on Māori and Pacific workforce, because that workforce is not seen, like it's not observed. The percentage of Māori and Pacific in our population is not observed in the number of employed staff. That we need to continue to be honest about shortages and gaps, and that we'll continue talking about some of the work that we've done to improve longer term challenges. But what will be different, there'll be a longer term focus. We will look to focus more on primary and community sector, and that includes speaking with the sector and gathering more information so that the sector is better represented in the planning. And then there'll be some deep dives, particularly in the rural area. So looking at specific workforces across the country that really need some focuses. There'll be more prioritisation and clearer milestones. So I'm here today to garner your thoughts. The health workforce team, a member of the team, Georgina Preston, attended the Dementia Leadership Group meeting in March, and asking them for their expertise to help form a plan that is better representative of the needs of the primary and community workforce, but also of those delivering care to those with dementia. And so this meaningful contribution, gratefully, the New Zealand Dementia Foundation picked up the pen and offered to prepare a submission to the group on behalf of the dementia ecosystem. The timeline for this is a bit tight. So as all things when we talk about the financial year, we write the plan in the hopes that it will get published in July. And so the team have given us the task of the sector as a whole, of the primary and community sector, or those who contribute to the plan, to give across information, data, findings by the end of April. And so I come with questions although the group does have the dementia action plan, and I understand that the network did do some really meaningful work last year talking about the workforce and its needs, which the group also have, that they want to continue asking questions in the hopes that they can better represent the needs of the workforce as it pertains to people living with dementia and their whānau. I guess for me personally, I'm here to talk about the workforce plan, but with my Ageing Well hat on, and with the knowledge that Te Whatu Order and the Minister of Health have responsibility for ensuring the Dementia Action Plan is actioned and implemented in a meaningful way, that when we talk to the reflections that I mentioned before about how the kaiwhina workforce has not readily been represented in the planning to date, that the informal or caregivers, carers and whānau and loved ones are not represented in the plan, that although today I come to ask these questions to inform the workforce plan itself, that if the focus of the plan has to be on the employed workforce or on specific priorities for this coming year that don't necessarily speak to the needs of those living with dementia, that there is other work that needs to be done. So I guess I ask these questions in an effort to support the workforce planning team and the plan itself, but also with the caveat that if the plan itself doesn't do what it needs to do for this significant health challenge, that we will take that information and use it in a different way to make sure that we meet our obligations under the Dementia Action Plan, and also just to ensure that we do the mahi that we said that we were going to do. So that's really the synopsis. I don't know if anyone from the New Zealand Dementia Foundation team wanted to add anything further, or if anyone had any questions. I'm more than happy to talk to more of the questions as well.
It's Shireen Maloney here. I'm the Chief Executive of the New Zealand Dementia Foundation. Hayley, that was a fantastic presentation, I think. It was a very full kite, and you unpacked it really, really well. There was a lot to say there. And just to emphasise that the workforce planning team at Health New Zealand just want to hear your views on these questions. That is the nub of what we're doing today, and that's what you'll get to discuss in your breakout rooms in a minute.
Can I just introduce myself, and then we'll go, get to Catherine and her question. Kia ora koutou, I'm Stephen Jacobs. I'm facilitating the next hour or two of this session, which is just to help you answer those questions. And we'll go into that in a second. But Catherine, you have a question.
Sure, thank you, Stephen, and thank you, Hayley, and nice to see you again. I guess I had two questions and a comment. So my two questions are, we're the Dementia Network. Obviously, we have a very strong interest in that language you used, a dementia-capable workforce, and I love to hear that. But the primary and community sector is much wider than the Dementia Network, and obviously we sit within a broader aged care network. So I'm assuming that there are similar conversations happening broadly, because I think we've all learned that thinking about the bits as bits rather than as part of an integrated sector isn't going to work. My second question is about family carers, and just checking how the health workforce planning around family carers is linking with the government's carers strategy and action plan, currently known as mahi, because that's the government's mechanism for supporting family carers. And my third comment is just about how we bring in some of the resources and opportunities that already sit in the sector but are not recognised and not formalised. And a good example of that for Alzheimer's New Zealand is, of course, our Dementia Learning Centre.
Thank you, Catherine. I'll leave those questions hanging, Hayley, for you to ponder and deal with at another time or later today, because what we're going to do now is go into the groups. And because what's important is that Hayley hears what the whole network has to say. So there will be 6 breakout rooms, and you will be assigned automatically to those groups, one of those groups, and you will have a 30-minute discussion. The questions will be up on the screen in your breakout room, so you're asked to go through those 4 questions. Please identify one person as a speaker, and the speaker will take notes and will be the person who speaks in the second phase, which is the discussion group. In the second phase, there is a panel discussion, and only one person from each group will be able to join into that panel discussion. So make sure to choose who that person will be. You'll get a notification 15 minutes from the end, about you're halfway through, and you have got 15 minutes left to have your discussion, and you'll get a 1-minute notification of wrap up, and then you'll be brought back to the working group. When you come back to the working group, speakers will be identified, and they'll be visible, and everyone else will be asked to be on mute and not be involved at that point. And it is a discussion. We're not going around each group one by one saying, what did you decide? It's like, we'll start with one group and then basically get all the panelists to add to that, so that we don't get that repetition you often get when you get feedback from groups. But I'll explain that all again when you come back together. So at this point, what you're doing is you're going into a breakout room. There will be the questions you're going to be asked to discuss will be visible on the screen that you look at, and you need to identify a speaker who will take notes and will be a panelist. Is that all clear? Any queries about that?
And if I can just say, we'll come back to they're very important questions that Catherine asked, and we'll come back to that as part of that panel discussion, and Hayley could contribute to that at the time.
So this is your chance to have a vigorous discussion and to get your points across. So I think that you're now going to be automatically put into groups. So the idea of this approach now is that the first speaker will start talking about what they discussed in their group in the first question, and then the others will add to that and talk about that rather than giving a report from their group. So you might say, yes, we agree with all that. Don't go through each point one by one. Just add to it so that it's a full discussion. And you might want to disagree as well. So, it's not make it a discussion. So has anyone got who would like to go first?
I'm happy to go first.
Thank you, Lara. So on the first question.
So this was what was missing. So we had quite a long discussion about the importance of early diagnosis, and what we talk about quite a bit with these groups is the difficulty people getting a diagnosis. But the main thing that we thought with gathering data on the workforce was actually identifying who is the dementia sector workforce, which is really, really tricky because this can include paid workforce, and often that's highlighted with GPs and nurses, but there's the allied health and multidisciplinary. There are NGOs, and these are non-Western organisations and the Pacific communities. And there was a discussion that some of the non-governmental agencies and community groups may not be aware that they are actually part of the dementia sector. And then you've got the volunteers and informal carers. So we were talking about really identifying and doing a stock take of what actually is classed as the dementia sector workforce. Is it paid, is it unpaid, and trying to actually tease out who they are before we can even get any data.
Good. Any comments on that? What additions to that, anyone?
It's definitely support that, and the different settings and points of engagement, and where there's insufficient current workforce to respond to demand at different setting points on the journey.
Yeah, and I think something we touched on was around there's different touch points. So even though your job might not be, you might not be paid to support somebody with dementia, but part of your role is because you work in a different service, and then people come along who haven't, like you said, but Lara, people maybe haven't got a diagnosis, or people don't know, but they're supporting and navigating people to get support, or they're supporting people at that point. So actually it's a bit of a difficult thing to capture, isn't it, around actually, because the touch points come into different places at different times and different services. And so people might not sit under a specific service offering services to people living with dementia. They might sit under a different service altogether. So then how do you capture that workforce? I just think GPs are a good example, or MPs maybe, that you see people who've got a diagnosis. So it's a really quite complex thing to gather. And then you got to take all the unpaid workforce, which is similar to what Lara said. So
yeah, I mean, I think our group agrees with all of that. I guess the things I would add to that discussion from our discussion is the fact that there isn't nationally collected and available and visible data now is yet another reflection of the invisibility of the experience of dementia and our sector within the broader health sector. And, part of this is about the health system taking responsibility for recognising and identifying this part of the sector and seeing it as being part of the core and not an add-on. And the second part of it, which I think is picking up, those last comments by Kathy and Lisa, is about the fact that we are part of something bigger. So it's not, you know, it's not a dementia issue on its own. We're part of a larger part of the sector. Some people work only in dementia. Some people have people with dementia as part of their client group or they're part of their practice. So it's both and identifying what we mean, but also those connections.
Great. Anyone else?
Yeah.
Yeah.
You're muted, Teresa.
Oh, Teresa,
Oh,
yes, Teresa. you're
Teresa,
muted.
go.
Sorry. Oh, I'm unmuted now.
Yeah,
So
you can hear you now,
we
yes.
totally agreed about not knowing what the need was, not really understanding who the workforce was, and we've got no way of collecting that data. But the other thing that we were mindful of is that the framing of the shortage is really about what's happening in the registered workforce, as opposed to some of our discussion in our group was that there's not a shortage in carers. You know, when a company or a provider is trying to recruit carers, they've got a waiting list, but alongside that is the need to make sure that they're getting consistent and well-founded education and support.
Great.
Definitely.
Yeah. No agreement on that? Yeah.
I also think, just to add, if that's okay from our group, definitely agree with what everyone else has said, particularly around recognizing, you know, so-called informal whānau carers. Is there a way we can get accreditation through NZQA, you know, following what's happened in, you know, similar models in Australia of actually recognizing whānau carers as skilled, and acknowledging the you know, the core work that they're doing, not kind of additional work, particularly because we do have major workforce gaps in terms of what people can provide. Also, in terms of workforce itself, there's a funding mismatch, because we do have very skilled, you know, kai mahi. For example, we had a psychologist in Aotearoa who talked about developing, you know, tailored training and programs to support people living with dementia mate wareware and to support staff to build their capability. But at business cases to get funding for those kinds of, you know, New Zealand made tailored training were pushed back. And then there was generic training offered by Te Whatu Ora nationwide of an online American training based on people going up to an emergency department reception, you know, rather than a holistic approach to looking at different care settings. So I think the expertise is there. It's in the Te Whatu Ora workforce itself, and it's also definitely in community organizations, nonprofit providers, and for-profit providers as well. But how do we actually scale and replicate and ensure that there's access across the country to what at the moment is pockets of good care and good work being delivered by specialist workforce? Yeah.
Thank you, Natasha.
Mm.
Any other points on that question? Okay.
And just really quickly, sorry, a data point, which is really important around what is the data ethnicity wise on, you know, Māori, Pacific, kai mahi of other ethnic backgrounds. So we have a culturally safe workforce, and just getting better demographic data. So we see the gender, age, ethnic, rainbow, disability, diversity of our workforce.
Okay. Thank you, Natasha.
Mm.
Okay, question 2. Who would like to lead off on question 2? Catherine.
I was just about to put my hand up there, Catherine.
Catherine made it in front. Go, Catherine.
Two critical things from our group. So, and a point in front around the voice of carers needing to be really central to any development. So the concept of establishing a dementia knowledge and capabilities workforce framework to actually give a solid foundation for really responding to the things that have just been raised. And that would also define the skills, obviously skills and knowledge needed. And that would be across the entire spectrum and all those points we talked about. And then just to say that in the community-based setting and working with Alzheimer's New Zealand, Dementia New Zealand in a partnership, including with carers around the table and a lived experience of dementia, is the recent development of the joint service model that speaks to the Dementia Mati Wareware Action Plan, and it has been fully costed. And within that model, the most significant costing has been the workforce and defining what is the workforce for community-based post-diagnostic response to people living with dementia, and how do the person and their carers get supported in a comprehensive range of evidence-based practice to respond to need. If those two things were developed, that would speak significantly into provision of a workforce that could respond to need.
And just adding to that, agree with everything that Kathy just said. But also in our group, I think that where we started in thinking about what would make the biggest difference is in thinking about, well, how do we build a successful dementia-capable workforce for the future? And we saw that the starting point of that was actually about tackling the stigma and discrimination associated with dementia, and also raising awareness of the impact of dementia and how it affects people in the community, but also the whole of the health system. The second part of this is not going to be welcome, but the pay and conditions issues and the equity issues between our part of the sector and the other parts of the sector are a major issue and have to be tackled head on. And then the third part of this is about thinking about the planning for future needs. And in that, we were thinking across the whole spectrum. So thinking about changing the focus of the, or not the focus, but the balance in the workforce to recognise the need to focus on prevention and early detection and have a workforce capable of doing that, and also understanding of dementia in that space. Having the volumes of people available to respond to the increasing demand, and having the services in the community able to deal with that demand coming through, with priority on things like the caseworker or the case manager, navigator, however we want to describe that, and CST, and the community-based services and supports, all of which were in the service delivery model that Kathy was talking about. And that is actually integrated with the wider sector. So that would make, we think, a big difference.
Thank you, Catherine. Anyone else like to add?
I think ours was similar to what Catherine was saying, but we kind of talked about that workforce kind of like taking a step back in terms of, when we've got a workforce that actually got some knowledge and awareness, and so actually that can help to lead to an early diagnosis or a recognition of what people might need as well. And I guess also, Catherine, similar to that, breaking down that stigma, and we talked about, and you've said it should be like diabetes, it should be something that we just get educated around, and that should be part of our core training, so it's not something different or not the norm. So I guess we took a step back and just kind of think about that preventative model, and I kind of think about the work that Scotland do, really about like educating children, and kind of actually where they start their education from is that kind of, and they educate their families, and so actually how we start to do that on a broader spectrum, because they're doing phenomenal work in the space, and so actually looking at their models, because obviously that's working for them, and actually something similar would be great here, wouldn't it?
Yeah. And I think adding to that, and this next point really came up in generally in our group, but in response to the next question, But, you know, when you look at what is possible in places like Scotland or in Australia, the big difference is money. And we had a conversation in our group about the fact that a big constraint here is that there isn't money for these services, but there also isn't money for the education programs. And I you know, made the point that we have the Dementia Learning Centre. That is the centre that delivers the CST training for CST facilitators. Has the master trainers in it, but we also have a lot of other programs that tackle awareness and other things. And we don't get any money for that. There's no money for anything that we do in that space. So, and I know we don't have that alone, but how are we going to get to the point of having a skilled and capable workforce if the system isn't investing in the education component of that across the board?
I just wanted to tautoko that, Catherine, because I think, you know, there have been workforce surveys. So, for example, there's a really great workforce survey done by AUT. I think Catherine Ravenswood and another researcher on the home care and support workforce and the impact of pay equity settlements. And one of those that I found really interesting was that senior healthcare assistants and home and community support workers were not getting the hours that they wanted because it's just not feasible to hire the sometimes really senior home community support workers that we might need that could support people living with dementia, mate wareware, and their whānau. It was, you know, obviously cheaper to hire people who were more junior, and that doesn't mean that they wouldn't still provide good care, but it's about this sort of quality of care trade-off ultimately that happens on a broad scale because of pay and lack of funding. Yeah.
Okay. Any other additions to that from the other groups?
I think that we discussed funding as well, but the important thing for us was that there is a tendency to think that the money needs to all go to residential care and that late stage dementia, whereas, you know, early diagnosis, midpoint in dementia, those are the areas which are not well funded. And so there needs to be a shift, a redistribution of where the funding is. Or more funding, but a redistribution in the focus.
Okay.
Yeah. We also talked about funding and the fact that, you know, there's lack of individualized funding and flexibility and support and the lack of cultural diversity in the sector. So more needs to be done in that respect.
Any other points? You're going through this very fast. Point
Really
4.
quickly, sorry, can I just add?
Yes, absolutely.
Just building on what was said about lack of cultural diversity in the sector, I wanted to pick up a really good point that Andrea shared. I think we also need to reframe how we see the sector, because there is actually really good work being done by culturally diverse organizations, but it's not recognized because it might be marae based, or it might be within a Pacific, you know, a church group setting, or it might be within, you know, Asian community settings, and those groups might not be front and center of Te Whatu Ora's strategic planning for workforce capability. Because Andrea shared some really good mahi that she did with Macarena Dudley and I think Sir Richard Fall around bringing people onto marae settings and talking about mate wareware with kaimahi. So I think that there needs to be a reframing of who the workforce is, rather than constantly being in that deficit model of, oh, there's a lack of cultural diversity and where are the workers? We all know where the workers are because we'd go to them in terms of our lived experience. We'd go to our own communities.
Good, thank you. Now, what else have you talked about in your groups? What haven't you mentioned that needs to be mentioned from both the first 3 questions, but also the question 4? Lara, can you read question 4 out for me?
That was anything else.
Yeah, anything else? So
Anything else?
anything else? So we've covered the first three. What's missing from what you've said already that was discussed that actually is important to bring out, and what is anything else that hasn't actually been covered by those three questions?
I think there's two things that haven't been covered. One is we don't have good systems in which people can get good information. So in our group we talked about AlderNet. That's a new, I don't know it.
No, it's not new. No,
it's not new. No,
it's been around for a long time.
But people don't know about it. Well, I certainly didn't know about it. But the issue here is, where do people get information about who to go to? What kind of care is available? What kind of funding is available? That's one thing that's missing in the system.
Yeah. Okay.
But can I just, I'm not part of the speakers, but I've developed Harris List, and you need that's the navigational tool. So when you're saying, Teresa, where do we go? That's what I've created. So you go onto the list and it just they say, where do I go for funding? It takes you to work and income. Where do I do that? What do I have to do? It takes you to NASC. So please have a look at it, because I have spent a lot of time developing it, and it's fantastic, and it's devoted to dementia. So I know you're saying that's what we need, but I'm trying to create this, and I've created it, and it's it's got 12,000 users at the moment. So please have a look.
Leslie, what is it again, please?
It's Harris List. It's actually, my father had dementia, so it's I went off and I did a diploma at the University of Tasmania in dementia care, and so I've developed Harris List. So it's www.harrislist.co.nz. If anyone wants anything put on there, just contact me through the site. I'd literally do it for the love of, I don't know, but it's been, the use of it is fantastic. And that was in my head. It was, everything is all over the place. We've all got fantastic resources. How can we bring it all together for the people of New Zealand to know what to do?
Right.
So, yeah, anyway, please have a look. I'll unmute now.
Very useful, Leslie. Teresa, you had one more point.
And the other thing that we talked about was, I suppose, is staircasing. So that's been a concept that we have, that the workforce developers in New Zealand have been talking about for many, many years. But we have, one of our group talked about the fact that there's a nursing bridging course, but it's been put on hold. And so they're sending one of their staff over to Australia to do that and whatnot. So those are some critical components where people who have a whole lot of skills, but they want to have a step up in their career, and we don't have good mechanisms to do that.
No, I think that's right, and that certainly came up in our group as well, Teresa, about that kind of qualifications framework and how it kind of works, which is something that Kathy Perry, the director of our Dementia Learning Centre, has been giving some thought to as well. The other thing that came up in our group, which is changing the topic just slightly, but I'll mention it because it hasn't come up in the discussion so far, and that is a view and an experience that ours is a sector that is not attracting young people at the moment. And that, of course, is a major issue for us, given the demographics that we're going to be facing in terms of an aging population. And so, you know, we didn't know that we necessarily understood all of the things sitting behind that about why young people are not coming into the sector, or indeed if it's true. That was a sense that the team had. But certainly, if we don't get on top of that, we won't have a workforce for the future.
Thank you. Now, just very quickly, we haven't got a lot of time left, but I'd just like to go back to question 1 and see if we can get agreement on what is one thing that could be done next year that you think would make the most difference. We've talked about money, but if we don't talk, if we apart from getting a lot of money, which we always hope for, what's one thing that could be done that you could agree on would make the most difference?
I would punch up and say it's data. So it's
Data.
knowing the need, and then having a broader look at what the provider sector, what the workforce looks like. So we've got a very narrow one. We need to extend it.
Yeah. And I would support that, because I think without that, our sector remains invisible and therefore can be ignored.
Yeah, I would
a national approach to that.
I would add to that, just to sort of, I mean, I think data is important, but I actually think the one thing that will make a difference will be political will, because we've got a health minister that's, you know, being a GP himself, has been very focused. If you look at the initial reforms that he's created in the health sector, it's been around GP and you know, primary care. He's been looking at EDs in hospitals. He's got that type of a focus that I guess we're looking for a broader reframing of what the health workforce looks like. And I think there is a lot of data there. It's about getting a political momentum behind that data to actually get in front of Te Whatu Ora and say, this is a really urgent issue because we have this massive population boom and a huge demographic shift that's happening. We know that there are just huge increases in dementia Mate Wareware, especially, you know, with young onset, Māori Pacific populations, Asian populations. This is an urgent issue that is also going to affect the GP wait list. It's going to affect the ED wait times. It's going to affect people's elective surgeries. It's a system-wide issue. So connecting it more broadly into the other workforce issues that are top of mind for the minister and the ministry and Te Whatu Ora, I think will also be really important. Okay,
so that's data and sort of political awareness or public awareness. Political awareness you're actually talking about, aren't you? Basically.
Well, if you look at what happened in Australia in terms of actually big shifts with the Royal Commission and with changing their aged care legislation and funding models, that actually came from a lot of media and public attention on some horrible cases of people, you know, dying, receiving mistreatment, having really, really difficult situations and their whānau. And then that became highlighted and that got into the public consciousness. And then the politicians had to respond. Of course, there was lots of data as well, and that's important. But I think having the political momentum and the advocacy is really important.
Anyone like to add to that? Okay, so the next one then, question 3 was, is there one thing that for you would mean that the next year you have been successful, there has been success in improving the focus and of dementia care and care for people with dementia? What's one thing that you would see as success? You'd want to, the key thing that you want to be successful in the coming year?
Well, I think we have to focus it back on workforce because that's what this topic was about. So it's how do we have a nationally structured and understanding of nationally around the data and building that framework for how the capability and knowledge that's needed, and including carer, where do the carers sit in that mix as well. Okay. And that span across the whole broad range of health practitioners, kai awhina at each point in the system. Yeah. So,
okay. So
we have to move in a national way and not just ad hoc in different ways. Okay. In different parts of the system.
So your key to success, you'd want to see a national approach to workforce. basically, by the end of the year.
I think that's what we talked about. Everything seems to be in silos. So actually, kind of, I was saying, there's pockets of great things going on, but like pulling the things together that are working and seeing how we can make that. I mean, we know there's variances throughout the country and different demographics and different groups of people, but actually there's models that are working, or this work that's going on. How can that be replicated so we're not reinventing the wheel? We've got some consistency and we're not siloed. And it's not like a postcode lottery, which is what we talk about, you know, that you live somewhere and you get an amazing service, you live somewhere else, you don't. So it's about how do we kind of address all that? I think that would be
Okay.
I think it's definitely important that we extend our understanding of the workforce beyond just the registered workforce. So we've got a whole community-based workforce that we ignore, basically. And that needs to be a very integral part of the workforce plan.
Yeah. Yeah, I agree with all of that. And I think the thing I would add is that in terms of the health workforce plan, one of the things that I found disappointing about the current one is that it assumed that the parts of the sector can be thought about on their own. But our sector is part of the wider sector, and what they do influences what we do. But we can't really influence what the rest of the health workforce does because they're bigger and they've got more money and the flow goes the wrong way. So if we're going to make progress in our part of the sector, the rest of the health workforce has to see us as being a core part of it somehow. Has to be clear that we are part of the wider health workforce in all of the ways that Kathy and Teresa and Lisa have described.
Okay. Thank you, everyone. Now, can I ask everyone to join in again and open their cameras so we can see everybody? Because we're going to ask Hayley to talk in a minute, and she'll be nice if she could see everybody. But before she does, while you're doing that, just say that as we come to the end that the leadership group is submitting to the workforce planning team in Health New Zealand, and the New Zealand Dementia Foundation, we're putting together the discussions that the network and the leadership group have already had, as well as today's discussion. And so they would like as much rich detail as possible about the stories and discussions you have had and shared. So can the speakers email the notes they have taken to the New Zealand Dementia Foundation? You might want to take a photo of your notes rather than having to write a whole lot of stuff down. You might want to just take a photo. And you can send them you could just reply to any notifications you receive from the New Zealand Dementia Foundation or to Bevan. You will also receive an email after the meeting with a link to a SurveyMonkey. And in SurveyMonkey, you will be able to share your individual stories so that the foundation can integrate them into the submissions, so that there is a mix of rich story alongside recommendations and things that you want to happen. So is that okay? So if you're a speaker, can you please, in some way or other, turn your notes into electronic form, either by writing them down or by taking a photo or scanning them and send them through to the New Zealand Foundation, Dementia Foundation. Thank you for that. I think that worked well, better than the one-on-one report from each group. It was good to have some discussion, a little bit of discussion, no disagreements. So I didn't have to referee any arguments. So that was it was very peaceful. So you've obviously got a lot of agreement. So Hayley, would you like to just have a brief say about what this has meant for you being here today?
Sure. So yes, a big thank you. Your openness and participation in this work is so important. And what has really stuck out to me in this conversation is, everyone does agree. There's this like individual thinking, but a real collective agreement. And it really resonated about the redefinition of how we define our workforce. And we've really focused in on what has traditionally been these hospital-centric registered workforces, and it really needs to extend our thinking as an organisation, and also the importance of these workforces that are often overlooked, i.e. the whānau, family carers. So yes, I really appreciate that, and I'll be sure to I'll be sure to meet with the health workforce team after we get this collective, the feedback back from all of you and from the New Zealand Dementia Foundation who are going to collate it all, to really sing home these key points that we discussed in this section today. So thank you. I know that there are probably some questions that you have, and I'm really happy to have individual conversations and to receive emails from anyone as well. So if there's any unanswered things from this discussion, please feel free to reach out. And if I can't answer it, I'll find someone for you who can. Cool.
Okay. And Catherine, we did have a talk about answering your questions, and so I would. It's a bit difficult because we're running out of time, but I would suggest that you contact Hayley individually.
Yes, please.
There's this private conversations offline at the moment, if that's all right. Is there anything else? And I noticed people have been putting a lot of information in the chat, so there's lots of things there as well. And I know that you're welcome to write, well, we've said the Survey Monkey, but you're welcome to write to the New Zealand Dementia Foundation as well with things that you want to add. Are there any other points before I ask Teresa to close the meeting? No, thank you. I'd just like to congratulate you for your attendance and willingness to be involved, and such a supportive environment. It's great. So, and I know how hard that dementia work is. So it's great to see you with that energy and enthusiasm and willingness to support each other. So thank you for being involved. So over to you, Teresa.
I'd like to support Stephen and his thanking everybody for their participation in the work that we've been doing today. At the next meeting on the 2nd of May, there will be a discussion. So Health New Zealand, Te Whatuora, will be coming to talk to us to give their feedback on the review that they started in July 2023 on funding and service models for aged care. And so this is the first phase was completed last year, and it looked at the analysis of gaps in current service provision. So this now that was the first phase, and the second phase, they're meeting with different sector groups around the Motu, and they will invite participants, so we'll be invited to critique the findings and recommendations of the assessment, and we'll seek feedback and ideas. So we'll probably run the similar event that we've run today. So it'll be on what Te Whatuora has found in looking at the funding and service models for aged care. So with that, I'd like to once again thank everybody. And it's nice to see everybody, and it's nice to meet new people too. And so if I'll close with a karakia. So unuhia, unuhia, unuhia ki te uru tapu nui a tāne, kia wātea, kia māma, te ngākau, te hinengaro, te tinana, te wairua i te ara tangata. Koia rā e rongo, kua wātea, ai rā, kua wātea, e rongo, whakaihiria ake ki runga kia tina. Haumie, koie, tae ke. Ka kite.
Ka kite.